All right, and welcome to the July. Yes, I know it's August, but it's still the July. Why does healthcare suck? That's right. Hey, when healthcare sucks, you can talk about it whatever month you want to. But this is the July. Why does healthcare suck? And we did have to move it to today, but I promise you, it will be well worth it. We have such a hugely important topic that we're going to talk about today. And I am so excited that you will get to hear from our special guest today. I had the extreme honor of sitting through her presentation at the NABIP National Convention in Chicago just about a month or so ago. And I was just absolutely spellbound by the information that she was sharing. I had never really heard it presented in the way that she put it out there. And being in kind of the healthcare world for years and years and listening to people talk about the different issues that they had, man, I was able to pinpoint so many things that I've heard people talk about that doctors told them may well have been other things that as I'm listening to this going, oh my gosh, how many people have been misdiagnosed, maybe even given the wrong medications, maybe even being put in a worse situation because the individual, the physician even that was listening to them may have got bad information, stay with me, from their parents. How about a crazy deal like that? And to really bring this home and talk more in depth about this, and I'm telling you, you guys are going to be knocked out of your socks today. We got Karinn Glover with us today. She is a physician. She's a doctor. She is, man, I'm telling you, she is awesome. And I am so excited to have her with us today. And thank you, Jessica Brooks Woods, for introducing me to her. And thank you, Karinn, for being with us today. It is an extreme honor to have you with us.
Thank you so much for having me. And yes, shout out to Jessica Woods. She has been, Jessica Brooks Woods, she has been super supportive and very thoughtful about bringing vital information to people. So I'm really, really happy to be here with you.
Yeah, absolutely. Yeah, Wendy's kicking up a comment there. Wendy was in the class with us too, and she is excited to be with us again. Thanks a lot for being with us today, Wendy. All right, so let's jump right into this thing because we really have a lot of ground to cover, and we want to give a little bit of time at the end for people to ask some questions. So I'm going to go through a short list of symptoms for menopause that you told us about. Short list, folks. Okay, y'all ready? Brain fog, headaches and migraines, hot flashes, night sweats, sore breast, irregular periods, vaginal dryness, loss of bladder control, urgency to pee, reduced sex drive, mood swings, dry eyes and changes in vision, vertigo and changes in hearing, burning mouth syndrome, heart palpitations, shortness of breath, frequent UTIs, changes in body odor, itchy skin, cold flashes, tingling extremities. What the heck is going on?
And so, for the folks who can't see me right now, who are listening to the podcast, just envision me sitting here listening to all this and having tears streaming down my face as Harlon discuss all this.
That's what I look like when I'm in your class. I mean, this is one of the first slides up there, and I'm looking at this going, oh, how do you even survive going? I mean, wow.
Yeah. It is, I think, a uniquely feminine or woman experience to have so many symptoms and have this much suffering and have the medical community be like, yes, that is correct. All of these things are happening to you, and it's just a regular Thursday. Have a pleasant day.
Have a good day.
Right. Sorry for your suffering. That sounds awful. And also, we have nothing for you.
Take 2 aspirin and call me in the morning.
Yeah. And also, aspirin's not going to do anything.
But okay, so let's go back and let's really kind of dig into that list, because there's so many things that are on that list that literally could be attributed to something. And let's be honest, could be something else, right? It literally could be something else. because we're not just talking about menopause, we're talking about perimenopause too, which is it can be extended, as you terrifyingly told the women in the audience that day, 10, 20 years that someone could actually go through this. And that's before you get into menopause. There's all of these things. And then after you think it's over, it may not be over yet.
Yeah, I mean, typically perimenopause for American women, it depends on ethnicity and lots of other factors, whether the person is smoking cigarettes or not, and how often they do that. Folks who smoke cigarettes usually have earlier onset of it. Usually the average age for perimenopause and menopause is like 51, but for some folks, it comes earlier. For other folks, it happens later. And again, like I said, African Americans, Latinas tend to have symptoms that are more severe and last longer. Asian women seem to be winning the perimenopause contest, if you will, in that their perimenopause symptoms last only maybe 3 years. White women are somewhere around 4 years, 5 years.
So when you've got all this stuff going on, and because there's so many lists of so many things that it can be, right? Obviously, I gave this long list. Doesn't mean that everyone has all of these things happen.
Exactly. Yeah.
It just means that these are things that have been attributed to it.
Yes. And it doesn't mean they're all happening at the same time. Some people go for a few weeks with terrible hot flashes and night sweats, and then their hormones sort of fluctuate and they're fine and they go back to sleeping beautifully. And then it starts back up again. So it kind of, for some people, it goes in waves.
Right. And I mean, that makes perfect sense that would happen because, there's that fluctuation. And then there's also, especially with the perimenopause, it hasn't really kicked in yet, right? So there's kind of these beginning things, and it's totally a guess. I don't remember. You may have talked about this, but that would seem to me to be the time that it is a little more difficult to think of what's happening next because there is those fluctuations. You're not really in it yet.
Yeah, exactly. So to be formal about it, perimenopause is the lead-in, the years that pass with those kinds of symptoms that you outlined, leading up to the final period, right? And menopause is declared when there has been no period for 12 months. Okay. If the period comes back in the 11th month, if it's gone and it comes back at the 11th month, that means you are still in perimenopause, right? But if the period has stopped for 12 months or more, it is menopause and it ain't coming back. That's what we say.
Okay. All right. So that's the clinical, but that's good to know. That's the clinical version of that.
Yeah.
But let's talk about the other ramifications of this. And this is one of the things that you certainly brought to the forefront in the time we were talking. And that is the stigma that is attached to this, where women do not feel comfortable talking about it, including in their own family, as you gave an interesting testimony about too.
Yes, absolutely. Right. So because perimenopause symptoms often involve, like you said, and like we talked about in that workshop that I did, it can involve changes in the pelvic floor muscles to the point that the person has trouble controlling their urine, right? And there may be some leakage when they laugh, when they cough, when they're lifting something heavy. So the idea is that some of those are, you master the art of holding your urine when you're about 3, right? And so you know yourself to be an adult who can hold their urine and control it, and to be at a point in your life where you are maybe a manager or a CEO, right? Or simply somebody who just wants to function and control their bladder. But to know that you may leak and you may end up smelling like urine, or that you have to go change your underwear, all of that can be deeply humiliating. And nobody wants to talk about it and risk being stigmatized. They also don't want to color it negatively for other people. So I understand the reason in some ways for the secrecy, but I think what what often happens then, as you know, is that vital information is being withheld, and the ability to prepare is also not there when we don't talk about this stuff in our 30s and early 40s.
Yeah. Can you imagine, folks listening out there, that you are, as Karinn said, you've moved up the food chain here. You've got this very important role that you're doing, and all of a sudden you sneeze and you weren't expecting what just happened. And then what do, right? Well, you're in a boardroom. How do you excuse yourself? I mean, because you weren't ready for it, right?
Right. Exactly. So I have a patient who is a leader, and she has to stash poise pads, right? Like the urinary pads for incontinence. She has them stashed in her office, so that if she has an accident at work, she will be able to sort of recover quickly. She keeps a change of clothes on her at all times, right? And so when we think about the loss of sort of her sense of personal autonomy, her sense of being a functional adult, not to mention her loss of productivity and the possibility of presenteeism, right? That she's sort of at her desk, but not really there because she's thinking about, like, did I soil myself? Do I have to, right? What sort of contingencies do I have to plan for? We think about the kinds of conversations that she might start having. Well, maybe I shouldn't be working anymore if I need to be close to a bathroom all the time, right? And so, to your point about what happens when we show up for help, are doctors able to say, oh, this is part of perimenopause and there's ways we can help you? And are doctors ready to have that conversation?
And I think that's the vital point here is, if you get over it yourself, and say, I am going to talk to someone about it, and you go to a physician and you're given what you said earlier. Oh yeah, of course. It's just that time. It's just that change. This is just going to happen. And that's the help you get. You didn't get any help. And now you feel, once again, I can't talk to anyone else about it. And my doctor's not taking it seriously. So,
Right. And so in conversations with my patients, I've been able to say, have you talked with your doctor about pelvic floor therapy? Learning how to do the exercises that are going to strengthen your pelvic floor so that you can regain control of your bladder again. One of the hardest things is to tell people they're actually, if you want to try a medication, that's a possibility. You can also do these exercises. It does involve going to see somebody, and you will not be able to wear your underwear. Somebody will have to feel out some of the muscles there and do some testing. But it has been shown to work. And will your insurance benefits cover that? Right? And these are not conversations doctors are trained to have with their patients. Doctors are often trained to say, you know what, there's a medication for this, and it may affect other parts of your body. Sorry about those side effects, but I'm sure you'll be okay, right? Doctors aren't really taught to prescribe vaginal estrogen, for example, and to say that that's going to actually prevent urinary tract infection as you get older, right? And it does not have any relationship with the possibility or risk of cancer, right? These are nuances that not too many clinicians know about.
And okay, so Don McFarland just made a great comment saying that there are a lot of female doctors out there now that certainly can relate. There are more female doctors. Her exact comment was, now there's more female doctors can relate, so they know better how to find solutions and share. And that is absolutely a true statement. As long as you go to one that's not from that school, if we don't talk about those type of things.
Exactly, right? And so the tenacity that we're essentially asking folks to have, right? We're not only saying, okay, you've come to terms with the fact that you leak urine. It's kind of humiliating. Your pelvic floor is doing funny things. You can't count on your body to just naturally do things or automatically do things anymore. You got over that. You talked to somebody and they made you feel like you should just suffer and that there's no options. And now I need you to get over that and go find somebody else to engage about this thing that's kind of humiliating and really tough. And that makes you feel like you're completely isolated. It's a lot to ask.
And it really is. And I think the point of all of this is it's twofold. It's like so many other things. It's twofold. One is there is without a doubt the physical things that are happening. The physical, you can call them limitations, you can call them changes, you can call them whatever you want to. But there's the mental side.
Yes.
That is even more taboo because, especially in the generation of people that are being affected by this right now, we're still from that old school of rub some dirt on it. And we don't talk about those kind of things. And I mean, that is, I know that since COVID, people are a little more likely to talk about things with somebody, but we're still got to overcome that stigma that we grew up with, that you don't talk about those kind of things. And only weak people go and talk to folks about this unless you're just crazy, right? And then if you're crazy, then you really go talk to somebody, but it's only because you're crazy. And that's just not true. But it's still that stigma because, once again, who told you about it? It probably wasn't your parent. Depending on your age, it probably wasn't your parent. I mean, even yourself, when you brought it to your mom's attention, she's like, oh, yeah.
Yeah. Oh, I mean, completely, right? Like, love my mom. She's amazing. And simultaneously, she was like, yeah, it wasn't that bad. And then when I went back to her, like, are you sure? And she was like, oh, wait, it was horrible. Right. And it was like, wait a minute. How do we reconcile what you told me last year? And then she was sort of like, oh, so I went like, did you ever try hormones? And she goes, yeah. And then it was sort of like a week later, she came back to me and she said, I don't know if I told you this, but it took us months to find the right hormone dose. So I was miserable for even that time. But right, like she was sort of like, it takes a while. And all I could think of was like, I'm sure there's so many more layers to this. You've been out of this zone for about 30 years now. Do you remember any of it? Right? Like, and if it's not top of mind, I sort of wish we had talked about it when it was top of mind.
Yeah. Okay. Great question from Wendy. Why are some doctors, personal trainers, et cetera, committed to gaslighting? I love that she decided to slip that in there and saying it's not a perimenopause issue, but it's an XYZ. This is kind of what I was bringing up earlier. That it can be misdiagnosed or just completely dismissed. What's the benefit to denying that the lack of hormones is a real thing? And, let's be honest, this happens in men and women, but in this case, of course, we're talking about the women's issue here, but without a doubt, it is something that they're like, no, that's not what it is. It's this. What's the benefit for them to do that? That's a great question, Wendy.
So thank you for that question. And I think it serves multiple purposes. I think our society likes to think that women are these mystical natural creatures who are sort of who should not be touched by medicine and unless it's in service of reproduction. Yeah. And so I think there's sort of this very limited scope of what society feels like women should be doing. And I think also it wasn't until 1993 that women that medical studies and medical research had to include women in the studies. Whole classes of medication and studies could be released, having never been tested on women's bodies until 1993. And so I have to believe that so much of what I learned in medical school, I started med school in 2000. That wasn't that long from 1993. So if anybody is a doctor and they're in their 40s or early 50s, chances are they learned from other doctors who were like, why should we include women in studies at all? They're just men with boobs, right? And so I think the culture of medicine has to change significantly, and that filters into all the other allied professions that work with women as well in the health field.
Yeah, there's no doubt. And one of the things you said, though, I do actually agree with, and that is women are very magical, mystical creatures. I'm just going to leave it right there, and not say they shouldn't get the health care that they need, but there's without a doubt they are definitely the fairer persuasion of the human race. What I'm really want folks to understand is that you shouldn't suffer in silence, right? You should not suffer in silence, which is what historically has happened. And we're not really talking about just this issue, but women's health in general has really kind of been, it's swept under the rug. It's not talked about. You, as you mentioned earlier, you sit at your desk and you do your job and you hope that someone doesn't notice that I'm in misery today from XYZ, whatever it is. Obviously, we're going to really emphasize on perimenopause and menopause today, but there are so many other things that can be going on with women because they are, surprise, surprise, physicians from long ago, different biological makeup. Okay, there's things that affect women in very different ways that they affect men. We do not think the same way. Venus and Mars thing, remember that, guys? That it's very much. It is interesting to me what you talked about, how the trials went back in the day. It also tells me they probably found a lot of more men interested in putting weird things into their body than they did women. The women are just like, no. They're like, okay, we're just going to exclude them.
That could also be part of the narrative as yeah, for sure. Yeah.
What do I get? We're going to give you $20. All right, I'm in, you know?
Yeah.
Okay, so let's get back in here. Yes, I know I go all over the place, right? So let's jump back into this because some of the other things that you talked about, which we actually were not on that list, but there can be some pretty major dermatology things that pop up, different MSK issues that come up because of this too, that once again make it, even from the person going through it, thinking that's not what it is. It is a different related issue. And therefore they may not seek treatment, or they may seek treatment for the wrong thing and even lead the physician kind of down the wrong road.
Yeah, I think it's really hard because I think we learn about aging in a way that sort of says, you know what, after a certain age, women and men's bodies are probably very similar, but we don't really learn sort of where that happens and why. And so essentially we learn, and I'm not sure about the general public because I've been a doctor since I was 30, but it's that time when women are post-menopausal, that their bodies are more like men's and men's bodies become a bit more like women's, that men's testosterone drops and women's estrogen drops and all that stuff, right? But up until then, the conversation doesn't go, oh, I noticed that your cholesterol has spiked and that that your blood pressure seems to be higher than usual. What are you doing with your lifestyle? Wouldn't it be amazing if a doctor said, your estrogen levels are dropping, as every woman's levels do over time. Your ovaries are less active. And that means that estrogen is not as predominant and it has lost its power on your circulatory system. And it means that lots of changes are going to happen. Let's work together to make sure that this transition is as peaceful as possible, and that you have the tools necessary to make it through and have good cholesterol, have a great blood pressure, and that you make it into your older age with no balance issues, no osteoporosis, that you have good balance, that you have good muscle tone, right? Like, it'd be wonderful if it were framed that way. It's not.
And okay, so why isn't it? In your opinion, why isn't it framed that way? Because what you just said makes sense and it's logical, which of course means it shouldn't be part of healthcare because we don't do logical things in healthcare. But
I was going to say the title of the podcast sort of said it all. There really is The tide, I think, is shifting because Congress just allocated $275 million to research around women's health, particularly in perimenopause and menopause. So I do think we will see some shifts in how this conversation goes. The trainings will start to happen for doctors and nurse practitioners to be able to engage their patients in ways that are more holistic, right? But I also think, Harlan, having listened to your podcast, that you know that there are multiple competing factors for the economy of medicine. And the economy of medicine dictates that you're a specialist over there, you don't take insurance, you're a specialist over there, but you're affiliated with that hospital. So that means I can't see you. And that means it's on the consumer, it's on the patient to integrate all this information from the best folks in the field. And because of that, I definitely think for the next 10 years or so, it's going to be a bit of an uphill battle. I think and the other women on this call and who are listening to the pod, we in our, early 50s, mid 50s, whatever, late 40s, we're walking. So like the folks in their 30s and 20s can run, right? They will be the recipients of the energy that we're putting forth right now.
Okay, so let's dig a little bit into what you just said, because what you're really alluding to, in my opinion, is that the way that the U.S. healthcare system is built, which we know traditional, where this should be found in most cases is probably in primary care, right? Originally, that's who you're talking to. Maybe you're talking to your lady doctor if you're going to see one of them regularly. But in this case, because if you're in the traditional health system, you only get 5 to 7 minutes with your physician, this probably doesn't come up. Or if it does, they just want to send you to somebody else to take care of whatever it is. You probably got a thyroid issue. You probably, right? I'm going to send you to this kind of doctor because that sounds like a thyroid issue to me. You can't control your temperature. That's thyroid. Oh, yeah. I'm not going to do any test. I'm just going to send you over. We'll get some blood work done, but we're just going to send it over to your endocrinologist or whoever that they decided you need to. Your blood pressure is really high and your cholesterol is high. You know what? I think you probably need to go see a cardiologist.
Right.
And because that's the answer.
And so that's where, having worked in primary care, so yes, I'm a psychiatrist, but I've been a psychiatrist embedded in primary care for most of my career. So I love my primary care colleagues, and I understand they're under tremendous pressure with time to get people in and out of their visits. And again, that conversation that you're talking about, the conversation where I listen to the primary care clinician listens to the patient and says, ooh, this is more than my 15-minute visit. Because she's coming to me with so many different symptoms. We got the urinary system. She's talking about her sex life. That might be psychiatry. She's talking about her blood pressure. That means, what if she does have a heart attack? She said she has palpitations, right? Because we know that palpitations are sometimes just a funny part of perimenopause and don't indicate that a heart attack is imminent in any way, right? But the ordinary primary care clinician might not know that all of this is part of perimenopause, and might not, even if they do know that, they might feel like they need the assurance of all of those different specialists before they prescribe anything besides weight loss, right? And then, of course, to center weight loss as the solution often misses that this person has zero energy, and they maybe have bleeding fibroids, so their iron may be super low. And here we are recommending a treatment for them, exercise, that's going to require our work in medicine to help them even get to the point that they can exercise. So there's so many layers to this. And if we don't have settings where clinicians can speak with their patients for a long enough period of time to sort through all this, it can result in a lot of frustration on both sides.
That sounds like direct primary care. Wow. Direct primary care, advanced primary care. Those are real solutions where folks take the time to get to know you, get to talk about these things. They also, and from the direct primary care doctors that I have have relationships with and I've known, they also don't wait for someone to come up with some extra training. They go out and they get extra training and they keep up to date with what's going on and the most common things that people like women's health and different issues. So they're on top of it, male and female. Now, there's no doubt I am 100% behind you guys finding you a female doctor that has a better understanding of what you're going through. I get that. I 100% get that. But I do know it's kind of interesting that you brought that up. And I think about my mom, who turns 80 this month, and I don't think she's ever in her entire life had a female doctor. She's always had a male female doctor because that's the only doctor you could get when she was young, right? When she was in the age when she needed one, that's the kind of that's who it was. It was all male doctors. So that's kind of what she always knew. That's just what she's always knew. Kind of an interesting thing. It just kind of struck me now thinking about my mom that still to this day, she prefers to go to a male doctor.
Yeah. I mean, it is. I mean, right. Because there was a time when women were not allowed into medical school and it was extremely difficult to have a family or have a life if you went into medicine. So the byproduct of that is, of course, a field that still skews its information, its focus away from topics that are really relevant to women through the lifespan. I could go on about all of this because I get fired up.
Yeah. Now, I want to point something out. If you're out there listening and you say, I've compared notes with some of my friends that we've talked about this thing, and it's interesting to me how different they all are. Well, one of the things that you brought up is that every perimenopause is different. So if you talk to 5 people, you get 5 different perimenopauses. Yes, you may have some of the same things cross over, but there is a really good chance that someone has something going on that you don't have going on, and vice versa.
Yes, and it depends on the time. So there was the time period and where the person is in early, middle, or late perimenopause. So there's this whole school of thought around the kinds of symptoms you see early on versus the kinds of symptoms you see later. So the period, the missed periods, things like that, that's usually happens later in perimenopause, and it usually tells us that the last period is coming, right? But sometimes that time of irregular periods, that can go on for years. So even if you're in late perimenopause, sometimes late perimenopause is a good 4 years. So all of this stuff is really relative. But the other thing I wanted to say, based on what you just asked me, is there was a whole period where one of my friends had tingling in her hands and her legs. And so she went to a neurologist. We went to med school, so we know exactly who to call. She called the neurologist. They worked her up thousands and thousands of dollars later. They said, "We don't think anything's wrong with you." And she said, "But I still have this strange tingling." Finally, she and I were reading the same perimenopause book, and it was like on page 3. Like, yes, tingling in your extremities, right? And so just imagine, first of all, how much time and money and anxiety could have been spared if we had all known more about perimenopause.
So you mentioned a key word there I want to pick up on, and that is anxiety. That is depression, even bipolar. Someone who may have had issues like this and then overcame them when they were younger are at pretty high risk to relapse back into these situations in perimenopause, menopause. Is that correct?
That is correct. So there's a lot of evidence that folks who have dealt with depression earlier in life and who have conquered it may have a resurgence of their depression symptoms in the context of perimenopause. They're more likely to have sleep issues. And as we know, sleep affects almost every other part of your life, right? For folks who have had bipolar disorder and had a manic episode, it can mean that they have a resurgence of their manic symptoms. And to be able to talk with your doctor and have them be able to expect this, right? 68% of women who had bipolar disorder had at least one major depressive episode in perimenopause, so that their symptoms may be shifting. Whereas they used to have manic episodes in the past, they may have terrible depression during perimenopause. And to know that that's nobody's fault, right? That's sort of part of the body and the brain remodeling itself. There's this wonderful book, I think it's called Perimenopause Brain or Menopause Brain by Lisa Mosconi. And she talks about literally the remodeling of the neurons and the neuronal connections that happen during perimenopause. And in many ways, they are key towards for our longevity. But the process of the remodeling, I don't know if you've ever moved your home. But moving homes, just even moving furniture, it stresses me out, right? So just imagine that the brain is being completely remodeled and you're expected to go to work and function and sleep and listen with empathy to people while you're having a hot flash and look out for the people you're mentoring, right? And all of those things, it goes out the window. Wow. And we hate to think of like that toll that it can take, right? Because it's preventable.
Yeah. So we had an interesting comment, and I think that this, I'm very interested in what you have to say about this, because this is for, it says, for those of us who do not have periods as a guide, this becomes even more of a guessing game. So think about someone who's had something happen in their life when they were younger, 30s or 40s, where they had female parts removed, that now they no longer have a period. They don't have any of those, some of those things to go on, right?
Right. Yeah. So I definitely have some friends who have had a hysterectomy, and they would sort of say, like, I think I'm in menopause, but I don't know. I mean, because their hormones were still, right, their ovaries were intact, right? And so for them, knowing some more specifics about how close they might be to the actual menopause, it has to happen through other means. Sometimes they go to a doctor to get their labs drawn, to get their estrogen levels done. Sometimes it's hard to know because sometimes those hormone levels aren't really to be trusted. So it is hard to know. It's an extra layer of complexity for sure.
Yeah. Vicki, her comment was, it's why men think we're nuts. So there you go.
And, if I could just say, like, as a psychiatrist and somebody who helps people with any number of stressors and chemical and hormonal imbalances, it is remarkable to me that women are the ones considered to be quote unquote nuts, when everybody, all genders, everybody has their things. Everybody has their things.
Oh yeah, absolutely they do. But typically they're thought to be nuts by the other gender, regardless, right? That's the way it is. I think a lot of times you get more understanding from people that are going through what you're going through, but not always. That's not always the case, because as you mentioned before, not everyone gets it the same way. And so just like the interesting thing to me is your mom was like, oh, it wasn't that bad, until she really reflected on it and said, it was terrible.
Yeah.
Because where are you in it, right? Are you well past it? Are you not to it? Are you in the middle of it, but you're one of those blessed people that just have not had a big deal with it? Then it's hard to empathize with somebody that is going through the difficulties, because you're like, well, I didn't, so how are you?
Yeah, absolutely, right? And one of the things that has come up for a lot of my friends who are going to the doctor is that their doctors say, well, I did some reading, and what you're talking about is not in the book, right? And if it's not in the book, then I don't really know what to do with it, because I know what's in the book. I took a test on the book. I know how to take the test on the book, and so I know what's supposed to be in there. You are not in there. And so a lot of my friends have had to bring more books, right? And had to talk with each other to just say, you know what, I may be an outlier, but I know my body and I know what's happening. Something is off. And the other thing that I wanted to say was I went to an interesting lecture on perimenopause, but it was for men. And it was about how couples need to approach perimenopause, right? Because what's happening to one partner has to be addressed by the other partner, because the other partner is going to be seeing it and dealing with it and dealing with the consequences of it, right? And then also because often when one partner is treated, the other partner says, well, I got used to the old you. Now all of a sudden, like, now you got all this energy. Who are you? What do you want me to do? And so sometimes it is really helpful to have both parties in the room to talk about the changes that are happening.
So another issue that I think is very important we talk about and can be attributed to so many different things, especially if you've kind of maybe had a slight perimenopause or you're hit by it really strong all of a sudden, and that is the brain fog. That is, all of a sudden, I cannot remember anything. I know we all joke about, why did I walk in this room? That happens to everybody. I don't care what gender you are. It happens to all of us. But we're talking about a different thing here. This brain fog, talk about affecting work. I don't care what your job is. If you have brain fog and you are just sitting there locked in place because you don't know what to do next, because you don't remember even what you were doing, that's a bad deal.
Absolutely. So some of the things to be more detailed about the brain fog issue, there can be issues with word finding difficulty. So for some of us, I'm somebody who has always been a very verbal kid as an adult, highly verbal. And to get to this point in my life where I have to search for simple words, I knew, again, something is wrong. And that's absolutely associated with perimenopause, right? So word finding difficulty. Then, of course, there's the sleep issues. And sleep issues can impact brain fog the next day. Of course, we're still recovering from COVID. And for folks who have had COVID repeatedly or who had long COVID, there's sometimes an overlap between long COVID and perimenopause related brain fog. And so the impact of it in our workspaces, especially if the hot flashes are not under control, is that attention is gone while somebody's having a hot flash. When somebody's having a hot flash, the only thing they can do is survive the hot flash. They can't listen. They can't talk. So all that to say that any and all of those things can contribute to attention, focus, and the ability to be effective at work.
So if someone is concerned that they may be in perimenopause, or they know they are, or they're sitting here listening and going, check, 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 check. Oh my gosh, check that one too. What is the best way to approach their physician to have this conversation?
I would say before you talk to your doctor, you have to do some reading, because chances are you might end up knowing more than your doctor, right? And no slight to your doctor, right? What I have found sometimes is that doctors are pulled in a ton of different directions. Our advanced practice professionals, nurse practitioners, PAs are pulled in a million directions. They haven't done all the reading. So it's on us to do the reading for now. Hopefully in 5-10 years, it won't be so onerous. But wonderful books to look into are the Menopause Diet Plan. That's one book that I have found helpful for some of my patients and for myself. There's the Menopause Manifesto by Dr. Jen Gunter, super helpful. There's another book called What Fresh Hell Is This? Another banger, as they say. It's so good. There's that new book by Mary Claire Haver, also really good. So you have to do the reading or listen to it on audiobooks. I listen to podcasts as well. So there's one by Heather Hirsch that is really, really good, that deals exclusively with perimenopause and all aspects of treatment. Because what you have to do is wrap your mind around the fact that you're probably going to have to make some major dietary changes. You're going to have to change your exercise regimen, perhaps. You're going to also have to learn to ask much more questions during your visits with your clinicians. And you might have to think about hormonal supplements, or if you don't go in the direction of hormones, think about what natural supplements you might want to look into. And that's herbs. There's lots of options.
Yeah, so let's kind of talk about some of those, and then we're going to take some more questions if there are any. You mentioned a list of a few different medications that someone, when we were in the meeting in Chicago, and then you also mentioned some more natural solutions. So talk a little bit about through some of those and kind of what they would be used for in certain situations.
Sure. So for folks who are open to medication, and it depends on what the symptoms are, right? So for folks who are having intolerable hot flashes and night sweats, I think it's important to make sure those symptoms are addressed, because out of control, just really persistent hot flashes and night sweats are associated with cardiovascular disease. And there's some research to show that the folks who have minimal hot flashes and minimal night sweats also have better cardiovascular health. So to me, that means I got to get those symptoms under control, because I want to live. I like my life. I want my heart to do its thing. I want my body to be able to enjoy life. So getting those symptoms under control is important. So if you want to go in the direction of hormones, you got to talk to your doctor and be ready for that discussion, because there might be some pushback. And then if you don't want to go in the direction of hormones, then there are medications called SSRIs and SNRIs, and we typically prescribe them for folks who are dealing with depression or anxiety. But they are actually incredibly helpful for hot flashes and night sweats. And so those are Effexor. Sorry, instead of giving the brand names, I'll just give the generic names: venlafaxine, citalopram, and paroxetine, for example. There's also gabapentin and clonidine. But then for folks, for my naturalistas, there are make sure you stop smoking. I recognize lots of people like to, eat a vegetarian diet. They love all the herbs, but they are still smoking cigarettes. You got to stop smoking. Right? And then, but of course, for the folks who want to try herbal remedies, there's black cohosh. There's, some folks find it really helpful, and other folks have not. There's a particular flower pollen, and it goes under the brand name Relizin, and it's made by the company Bonafide. So Relizin is Relizen, and I have tried it myself, found it super helpful for hot flashes for more than a year and a half. It was super helpful. I got to a point where it didn't help anymore, but I know folks who are still on it and they're really pleased with it. No side effects. I'll pause there.
Okay. I have a follow-up question on that then. How often are you seeing someone, like in your situation, where you're using something that's working and then it just stops? Is that I'm guessing that's just your body chemistry changing again and saying, we're not going to let that work anymore.
Yeah, nailed it. Yes, that is exactly what happens. That the hormone levels fluctuate. Sometimes it's the way that estrogen levels change in relation to progesterone. And it's not just that the estrogen levels are falling, it's that the ratio and the relationship between the hormones is changing. That can give people symptoms. There's one medication I didn't mention. It's called Veoza. It's a non-hormonal medication that has been shown to be helpful for hot flashes and night sweats. So I just wanted to mention that one as well. And it's not a psych med.
Okay, so let me make some clarifications here. The way I understand it, if you're doing the hormone therapy, though, you probably should not be doing these medications at the same time, because they are being affected by the levels of your hormones, right?
Correct. So specifically, so there are definitely lots of folks who are on estrogen and one of the psych meds that I mentioned, and I don't think it's quite fair to call them psych meds, but their biggest indications are for mental health. But so it's fine to be on estrogen and one of the SSRIs or SNRIs. What you can't do is take estrogen and be on Veoza.
Okay.
Yeah.
Okay. And I know a lot of people take gabapentin because it helps with tingling extremities. It helps with sleep. There's a number of things that it helps with. whenever they're severe, because I mean, I know a lot of people that take it, but then there's also people that say it simply doesn't work for, or that it causes a reaction. That's any medications. How effective these days is hormone therapy in reducing the symptoms
It's
of
extremely effective. Yeah,
perimenopause?
it's extremely effective with perimenopause. So it can get rid of the brain fog, word finding difficulty. It can get rid
What were you talking about?
I'm like, but the thing is, it's like I have to go back through and say, I'm looking for the word. I know it starts with an H. I know hot flash, vasomotor symptoms. So there are plenty of ways that that estrogen helps with the hot flashes, right? It is absolutely indicated. It is indicated for hot flashes and night sweats. Now, and it's been shown to prevent osteoporosis, right? So the bone density issues that can happen as women age. The hard part is that taking hormones can come with side effects. So there are some folks who, once they start the hormones, their fibroids may get bigger if they had fibroids to begin with, and that may lead to heavy bleeding, right? And in which case, like, you might just want to come off the hormones and just go find you some herbs and just see if you can tolerate it until perimenopause advances enough that you're not bleeding so much, right? So sometimes it's just a matter of time, but estrogen and progesterone have been shown to be very, very helpful, and also for the pelvic floor, and for preventing UTIs as well, and some of the urinary incontinence issues that people deal with as estrogen levels fall.
We have a quick question from Dory. What is a natural estrogen boost replacement? And she is very happy that we're providing some of the natural options too. But do you know of a natural estrogen boost or replacement?
Well, so there was a lot of talk back in the day about whether soy containing foods like edamame and tofu and having soy milk would have some estrogenic activity. And so it wasn't shown to be enough to make a difference, but because that was thought to be why East Asian women had such a much more pleasant perimenopause, because there's like a lot more tofu and soy products in their diet. So that has since come under question. I think there are other supplements. There's some folks like wild yam cream because it has some hormonal activity. From what I've read, the evidence is kind of thin. But look, I also know people who were like, wild yam cream forever. I put it on my skin. I look great, So look, I'm one of those doctors who says, if you like it and it's not harmful, go for it. Just because the majority of the people in the study didn't find benefit, that doesn't mean that those folks on the outer edge of the bell curve didn't find a helpful outcome. So you might be an outlier. Enjoy your outlier life. Get into that yam cream and look, keep your health costs down and keep your side effects low.
Yeah. So we have another comment from Vicky. Why in my day? She puts in my day in parentheses there. Did they say hormone therapy was bad?
Yeah, so it's because of the Women's Health Initiative, the WHI study that looked at the effects of hormone therapy over the long term. The hard thing, and so they found that there was a higher risk of endometrial cancer and that there was a risk of breast cancer. But what they didn't do was give it to people in their 50s, people in perimenopause. They gave it to women who were postmenopausal, women who had no more periods, right? And so it was tested on a different population. The folks who were younger and who started it within 10 years of their last period tended to do fine. And they didn't stay on it forever. They stayed on it for maybe 3 years or 5 years. So the research has come into scrutiny at this point, and people are saying, you know what? they didn't do this. They didn't come to the right conclusions for the right people. And so that's why we're taking a new look at the safety and coming to the conclusion that it's probably okay for most folks, unless there is a high risk of breast cancer in the family, or that they've got to be on transdermal estrogen, meaning they are not on the pill estrogen. They are not taking pellets and stuff like that. They are on a transdermal patch, and they get a constant flow of estrogen. And it's been shown that if you keep the estrogen levels constant, that it is much easier, or that there's a much better health outcome.
Okay. Way back at the beginning of the show, you mentioned in talking to your mom, and she was remembering what it was like, that they had a hard time finding the right amount of hormone with her. How likely is that? Or well, I won't say how likely is that. What is that still very common? Is it common for people to have a hard time finding the place that they are, or is the way that it's being given now, like the transdermal, helped that because it's not just, oh, what size pill do you need? Because you're getting a constant amount, it works better now than it did then.
So yes, that's such a great question. And so I can't really speak to how many people have difficulty initially, but what I can tell you is the doses that are available from pharmaceutical companies are sort of very discreet, and going between doses, you can't cut the film that is in the patch. So you get what the pharmaceutical companies make. And so if you need something in between, that's tough. That's hard on you, right? And so what it means is that you take a guess and think, okay, this person might still be this person is still menstruating. I can't give them the mega dose, right? Because their body is still making their own estrogen and progesterone. So I'm going to give them the dose that I think should work. If they come back to me and say, I'm having migraines, my breasts hurt, I'm bleeding, then you say to yourself, okay, we got to go down on the dose. And I hope that still treats your symptoms, but doesn't overwhelm your body and doesn't give you uncomfortable symptoms. And if you do end up needing that in-between dose, then that means we have to talk to a compounding pharmacy, and that's a whole other conversation. But there are practitioners out there who have very good relationships with compounding pharmacies, and they find them very trustworthy, and people are enjoying life and remaining healthy.
Yeah, absolutely. All right, we just got a couple of minutes left. I know Karinn's got a pretty tight schedule today. So if you got any other questions, you got a couple more minutes to get those in and get those answered before we sign off for the day. And I just want to, once again, thank you so much for taking time out of your very busy day to be with us. I know you got a lot going on, and it has certainly been a wonderful conversation. I know we've got a lot of comments of people very thankful for the insights that you've given today.
Thank you so much. I very much appreciate it. And I know that there's lots of folks who have questions about healthcare and how maybe insurance benefits could be structured so that women in midlife can be connected very easily to clinicians who are skilled in this way. So there are companies out there that focus on women's health in midlife. And I think it's wonderful if the employer has a benefit package that includes those kinds of clinicians. So there's a company called Maven. There's another one called MIDI Health. And all of those, there's others out there that are able to provide really, really good skilled clinicians to give people the right kind of information.
Yeah, absolutely. That's one of the things we take a hard look at when we talk to a company, depending on their size and what their dynamic is, as far as what their demographic is what type of services they need, especially on the women's health side. I mean, if it's a tech company with nobody over 28 years old, they have a whole lot different need than somebody, an accounting firm where everyone's in their 50s. It's going to be totally different needs there. So we certainly have to look at that. All right. We got lots of thank yous, and a big thank you from me. Read a couple of them to you. Thank you, Karinn and Harlon. Great conversation. Great conversation. Thank you for being a brave man to host this topic. And thank you, Dr. Glover, for sharing your expertise in this area. So thank y'all all so much for being with us today. I hope that you got some valuable insights. And once again, thank you so very much, Dr. Karinn Glover, for being with us. Hope we stay in contact. I would love to have you on some future events where maybe you can give an insight. We have some other folks on there as well. So thank you very much for being with us today.
I'm happy to be here. Let me know when the next panel discussion is. I'll be here.
All right, great. And folks, if you like this, and you're going to love next month because we're talking about men's health. That's right. That's right. Dr. Priscilla Osama will be with us next month as we talk about men's health. And I'm sure the question of hormones will come up again. Thanks again for being with us on Why Does Healthcare Suck? We'll catch you next time. We are out of here.